Okay. Okay, and I'm going to start sharing the screen. There it is. There we are. Okay. So good afternoon, everybody, and thank you for joining us. I'm Jed Levine. I am the President Emeritus, former CEO, and been here for almost 33 years, hard to believe. Back when we were the Alzheimer's Association, we've been caring kind for over 7 years now. So it's my pleasure to welcome you to Understanding Dementia, a meeting for professionals. And as I said, you didn't hear me before, I appreciate if you could put your cameras on, just so that I don't feel like I'm talking to a bunch of black boxes with names printed on them. And if you could add the agency to your name, that would be helpful to me just to see where everybody is from. Normally, if we were in the room together, I would go around, we'd introduce ourselves. But I think one, we have too many people for that today. And two, we have a lot of material to cover. So this is our Understanding Dementia, a meeting for professionals in the field. And we're going to continue. So my goal today actually is to give you, excuse me, give you an overview of kind of the fundamentals about dementia and Alzheimer's disease, go into some information about what both the individual with dementia is experiencing, but also what their family caregiver or other caregiver is experiencing. We'll talk a little bit about some of the research and some new, very, very new findings that are very exciting. And and that should take up our 2 hours. Let me remind you that if you are a New York State licensed social worker, you can earn 2 continuing education units. You simply have to call the helpline, and that number is 646-744-2900. Yes? No? I thought I heard somebody knocking. And request the CEU application form. You're going to be asked to complete a short questionnaire and return it to Caring Kind with a check for $40, or you can call and ask for Sue, and we can take your credit card over the phone if you prefer. And at the end, we'll also be sending everybody a brief evaluation. And I'll also be sending you our Caring Kind connection form. So if you have clients who could benefit from the free supports and services that we offer, and we work, with many community-based organizations, and it makes it easy to refer clients to us that way. We'll also be talking about some of the new and exciting new programs that we have for individuals living with dementia, as well as for their family and friend caregivers. So I think it's always good to start with the basics, and I think there's always a little confusion about what's the difference between Alzheimer's disease and dementia. Dementia is a broad term describing a group of symptoms. Actually, dementia is not a disease, it is a constellation of symptoms resulting from a disease state or an underlying medical condition. There are 4 primary areas that are affected, and certainly we think about memory first, and certainly the short-term memory that is impaired early in the process, and later on long-term memory. And but it's not just an amnestic disorder. It deals with all areas of cognition, of thinking, planning, reasoning, judgment, language, both expressive and receptive language, written language, and oral and spoken language. So it's a highly complex disease or a highly complex syndrome, and that's why it's been so difficult to to find a way to really treat it effectively, and also a way to eventually, we're not there yet, but a way of curing it, and also a way of what we're looking for is a way to prevent it or delay the onset. But again, it's not just memory alone. It's not just the cognitive thinking piece. It is also affects mood and personality. And these mood and personality things are often, oh, thank you, whoever put something in chat. Yes, you can get this PowerPoint as a reference at the end. Yep, we can do that. So let me remind you that if you do have questions, please put it in the chat function. So thank you, Shaheen. It's the behavioral symptoms, I think, that are most distressing, probably for the individual themselves, as well as for the individual who is taking care of them. And the other thing that we don't often think about when we talk about dementia is that it has a physical component. So you see things like reflexes, motor planning, gait, visual spatial planning is impaired as well. And again, those impairments happen a little bit later on in the process, but nonetheless, they are definitely a part of the illness. So dementia is this umbrella term. The most common cause is Alzheimer's disease, but it's almost never Alzheimer's alone. There's almost always some component of vascular dementia, dementia with Lewy bodies perhaps. There might be some frontotemporal dementia, which is different from Alzheimer's disease. We'll talk about all of these diseases as we progress. But most people have a mixed picture in terms of what's happening in their brains. And we can't discount the impact of dehydration, especially in very hot weather or times when people are not, adequately hydrating, or malnutrition as a cause, although we don't see that as often as we used to, perhaps, with better nutrition programs through, federal funding and Meals on Wheels and those kinds of things. Vitamin B12 deficiency can result in confusion, disorientation, and memory problems. And again, we don't see that as frequently. Often that's picked up in a routine medical examination, assuming people have routine medical care. And that's easily reversed with vitamin B12 shots. But again, I say that's fairly unusual. I don't think I've seen too many of it. Some people might have a thyroid issue that causes confusion or fogginess or memory issues. But again, those are easily treated. These ones that are spinning around are the ones that are easily treated. And the other thing we want to look at is medication interaction. And as you well know, working with older adults, that older adults are the largest users of drugs, mostly legitimate drugs, prescription drugs. But often those prescription drugs can have interactions that can cause changes in how they think and how they function. So one of the most important things that people who are doing an evaluation can do is to ask an individual to bring in all of their medications, both over-the-counter and prescribed medications. And often a good geriatrician will cut back the number of medications and the types of medications. And you'll see often that somebody will even if they have a dementia, that their functioning will improve because they're not being affected by some of these other medications that can cause cognitive and memory issues. So that's the picture of dementia. So now, how do we know it's dementia versus the normal changes in aging? And I will tell you that this is an area that is under and has been under research for many, many years. But generally speaking, we can tell the difference in terms of function over time. That in order for it to be dementia, it has to affect the individual's ability to function independently. And all of us, I'm sure you've lost your keys, or you have put something down and forgotten where it was. I just forgot where my laptop was. I took it out of my bag and put it near somebody else's desk, and I was like, what do I do with my laptop? But I found it. And when I found it, I knew what to do with it. I knew how to operate it. So the difference is that in normal aging, and most times, and not even for people who are really older, but for all of us who forget things, it's a matter of inattention. We're not paying attention to what it is that we're doing. And that's hard we have so many demands on our time, and there's so many devices and so many things that are distractions. When you walk into a room and you're not quite sure why you're there or what you went for, you have to stop and focus and concentrate, and you'll remember that. The person with dementia might not be able to quickly recall. They might be able to recall, but it might not be so quickly. And when they're there, they remember what it is that they wanted to do. The changes in language and the ability to put one's thoughts and feelings and wants into words. Occasionally, we all have difficulty, coming up with the right word for something, especially if we're tired, especially if it's between 4 and 6 at night, when we're, our diurnal rhythm is a little challenged. And but the individual with dementia over time has more and more difficulty expressing themselves, writing out words, and they have difficulty with the two-way conversation. And all of us occasionally, like yesterday was Martin Luther King Day, and I know that some of you woke up and thought, oh, I've got to go to work, temporarily forgetting that it was a Monday holiday. The individual with dementia loses a broader sense of, they are more disoriented in terms of date and season and day and month. And need a lot more cueing, especially early in the disease. Can be helpful. Cueing can be helpful. So generally speaking, we're trying to really differentiate what is that. There is a kind of a pathway between normal aging into something called MCI, which is mild cognitive impairment, into full-blown dementia. We'll talk about that in a moment. By the way, again, if you have any questions or comments, we're going to take several breaks because it's kind of hard for you to sit and listen for 2 hours straight, and just to see if you have any questions. But if anything burning comes up, just put it in the chat and I'll see it. Okay. The diagnosis of Alzheimer's disease and other dementias is actually now very standardized and with a very high % accuracy. This is done through a differential diagnostic process, one by taking a family history and a history of the onset of the symptoms. When did they begin? What did they look like? And then doing a complete physical examination, running blood tests, rule out any reversible cause of the disease, like a thyroid issue, or perhaps there's some kind of other electrolyte imbalance. And a good evaluation will consist of neuropsychological testing of memory, cognition, and personality. And that's often just to get a baseline so that we can see how things are progressing over time. And brain imaging using PET or MRI or CAT scans. Again, the purpose for this is mostly to get a baseline. You don't see Alzheimer's on a brain scan, but you can see brain shrinkage, and you can see if there's something else that's causing the problem. So maybe there is a tumor, maybe there is hydrocephalus, maybe there is a, something that is causing these cognitive changes, and you want to take a look at those. So, okay. Now, Alzheimer's disease, which we abbreviate as AD, is the most common cause of dementia, representing 60 to 80% of dementia cases. And, it's kind of the major illness. This is, in my mind, dementia and Alzheimer's disease specifically is the major public health issue for this century. It is progressive, it is degenerative, it causes changes in memory, thinking, all the things we just talked about, behavior and physical functioning, language. And at the current state, we are just beginning to have available disease modifying drugs. The drugs that we've had for the past 18, 20 years are really drugs that are symptom managing and really not all that good at it, frankly. So it's a very exciting time to talk about Alzheimer's disease and Alzheimer's treatment. So we recognize that there are actually 3 stages of Alzheimer's. One is the preclinical, meaning pre-symptomatic. So there are changes that are happening in the brain, which we'll talk about. And then it moves to MCI due to Alzheimer's disease. MCI, again, is mild cognitive impairment. And then it moves to the dementia phase. And that dementia phase is divided into 3 different stages: mild, moderate, and severe. And this can take a very long time, anywhere from 4 up to 20 years or more. And if you look at the preclinical phase, that can be 10 to 15 years before there are apparent changes in thinking, memory, and function. So we're talking about a really long span of time, which actually in some ways gives us more time to maybe use some of the findings which we're learning now about ways of either delaying the onset or managing the disease. So interesting. Now, we don't have the 23 numbers yet. Those will be coming out in March, and those are put out by the Alzheimer's Association. But the 2022 figures, we estimate as 6.5 million Americans are living with Alzheimer's. Notice I said living and not diagnosed, because probably only about half of individuals living with Alzheimer's are actually diagnosed with the disease. And every 65 seconds, another American develops Alzheimer's disease. This is a disease primarily of aging. So 1 in 9 aged 65 and older have it, but 1 in 3 aged 85 and older have it. And Alzheimer's is the 6th leading cause of death. And it's probably the 3rd leading cause of death for people 65 and over. It is, as I said, primarily a disease of older adults, but 1 to 3% are under the age of 65. And so you are set with a whole different, that individual and his family or her family are faced with a whole different set of challenges. If there are children who are still in high school or entering college, or maybe are in junior high school, if the individual with the disease has not done any retirement planning because they're only in their 40s or 50s. So again, it's a relatively small percentage, but nonetheless, for those individuals who are living with what we call early onset Alzheimer's disease, the impact of the disease and in the family is different than it is when somebody who is 85 years old. Now, by 2050, which is not that far away, it's not, like 27 years away, approximately 14 million Americans will have Alzheimer's disease. That's a huge number, which is why the work that's being done now in ways to delay the onset, prevent the disease, or have really significant treatments is so important. And we estimate that 1 in 5 New Yorkers will either have or be caring for someone who has Alzheimer's by 2050. 20%. Now, to understand the disease, you have to understand that, the brain is about a 3-pound organ. That's all it weighs. But it has 100 billion nerve cells. And between those nerve cells, there are 100 trillion synapses. That's where much of the difficulty happens, or the disease process happens. And it happens starting in the hippocampus, which the hippocampus is this area here, which is kind of what they call a horseshoe shape area. And that's where the memories are formed. If somebody has their, I can ask you to remind you to put yourself on mute. That would be great. Thank you. Appreciate that. Okay. So we're not going to get heavily into the physiology of this, but just recognize that there are two primary findings in order for somebody to have a diagnosis of Alzheimer's. To confirm it, there have to be plaques. And I hear some background noise. If everybody can put themselves on, please. Whoop, let me go back. Hold on a second. So the beta plaques are made up of this protein called beta amyloid, a particularly toxic form of the beta amyloid, and it's built up between the nerve cells, so the nerve cells can't communicate with each other, and that leads to cell death. And then within the cell themselves, there are strands of a protein called tau, which lead to the cell collapsing. So they're destructive to the integrity of the structure of the cell. And so these have been the two primary targets for research. Thinking logically, well, if we can remove or clear amyloid from the brain, well, then it won't build up and we won't have Alzheimer's disease. It's not been so clear. There's been some interesting developments lately. And the same thing with tau. If we can do something that will interfere with the production of tau or the overproduction of tau, well, then maybe we can do something about the disease itself. Okay. When we look at gross anatomy and you see the two brains, one on the left, which is the normal brain, one on the right, which is the Alzheimer brain, and you can see these are age-matched samples, you can see very clearly what the differences are. Now, if we were here in person, I would ask you to, let me know what you observe, but I will do this for you just because I think we have too many people on the phone to do this kind of more interactively. But you can see that here, the overall shape is much smaller. It is shrunken. So there is significant brain shrinkage. And the area between the two hemispheres and the sulci and gyri, the spaces are much wider. And it doesn't look as robust and healthy as this brain. There's simply not as much brain tissue. This is a very important photograph tool when we're teaching direct care workers, when we're teaching family members, because it shows that there really is a tangible change in the brain. And it's not because the individuals, they're not remembering because they're not trying hard enough, but it's because there are these, slow, progressive, degenerative changes in the brain over time. And I think this is a very striking picture and very helpful to kind of get that message home. So now, many people say, well, do we know what causes it? And what are the risk factors? And we're learning more about it. And then there's more and more confirmation about what those risk factors are. It's a complicated, and I've said this before, that the Alzheimer's is a complex disorder. And so it's going to take kind of a complex look at kind of what are the risk factors. So we know that aging is the greatest risk factor. Now, aging is a healthy thing. You want to age, and you want to age healthfully, obviously. If you're not aging, you're dead. You stop aging when you die. So we all want to keep aging and aging well and maintaining all of our function and mobility and our sensory ability and our cognitive ability until the very end. That's the goal. But aging, we know, is the greatest risk factor. We also know that genetics, that there is having a first-degree relative with Alzheimer's increases the risk, but doesn't predict that you're going to get it. In a very small group of families, there is a very clear genetic pattern. That is in that early onset component that we spoke about earlier. And here the disease, you see a pattern across generations where there might be 5 or 6 siblings and 4 or 5 of those siblings develop the disease. And in the generation above, in the mother's or father's family, same thing. And they might all get the disease by the time they're in their mid 40s or early 50s, and then they're deceased in another 8 to 10 years. So so in the kind of late onset Alzheimer's disease, the genetic component is complicated, gives us, there are certain genetic profiles that increase the risk but don't determine. And then in the early onset, there is this smaller number of families where there is a familial genetic component. We also know that race has some very interesting things to teach us. African Americans have twice the risk of developing dementia, and Latinos at 1.5 times the risk. There doesn't seem to be a genetic component or a genetic basis for that. There does seem to be that it's related to the fact that African Americans and Latinos have higher rates of heart disease, of stroke, smoking, don't have as much access to, they have higher rates of obesity. They don't have access to, quality medical care. And, it's all of the disparities that I'm pretty sure you must all be aware of. And so we see this, especially in the dementia world, that African Americans have twice the risk. Actually, a colleague and friend, Jennifer Manley, who is a researcher at Columbia University, has studied this and shown that we know that education is a risk factor. People who have lower levels of education develop Alzheimer's at a higher rate. And she's done some studies to show that African Americans who moved north in the Great Migration, that their childhood education in the South was not as good as education in the North for whites. Teachers weren't as well trained. There weren't as many, up-to-date textbooks and stuff like that. So anyway, it's a fascinating area of study. But we also know that there are some things that we can't control. One of the things that we can't control is who our parents are. But what we can control is that there are certain lifestyle factors. And those things that you've heard about around heart health, all those, eating healthy, exercising on a regular basis, getting good sleep, managing stress, managing the numbers, blood pressure, cholesterol, etc. The lipid numbers are all things that we can control. So things that are good for the heart are good for the brain. And clearly the brain uses about 20% of the blood that's pumped by the heart. So if there's anything that's interfering with that system, the cardiovascular system, the cerebral vascular system, you want to do everything you can to improve that. We also know that loneliness and isolation is something that's very detrimental and can cause dementia, or be maybe not cause, maybe let me restate that, but be a contributing factor. And so remaining socially and cognitively active and engaged are important tools. And for those of you who are working in the community and older adult centers and older adult community-based programs, it's really critical. And I think that, as you know, that COVID disproportionately affected older adults and disproportionately affected people with dementia, who were twice as likely to get infected, and their caregivers. And the social isolation, we saw that individuals with dementia, that their cognitive functioning decreased at a perhaps greater rate than it would have if they were more, if the sort of senior centers and the day programs were available during the height of COVID. There also is some interesting, I don't have it here and I should, but there's interesting work now about some sensory components, hearing loss, that long-term hearing loss that is not aided, that apparently the stress on the brain uses up more brain cells, to put it kind of simplistically. And so there's some really interesting research looking into the role of hearing loss in developing dementia, and also vision. So people who have had cataract surgery, there's some evidence that there is reduced risk because they're getting more sensory input. And then there's something about the, just make myself a note. Okay, the that if people have a high resting heart rate, just that there seems to be at an increased risk. And low resting heart rate is related, associated with a kind of healthy exercise pattern. So, any questions before we move on? I don't see any in the chat. Okay. Okay, let's move on. So I always put this slide up in every talk I give. I think it's really important. Oh, Diane. Yes, Diane, you can open your, let me see.
Hi, thank you. And I'm sorry I'm outside, so I'm just wait for the cars to go by for a second. And so one of the things that I'm very interested in, and the way, and you spoke a little bit about it in terms of race is not a genetic factor, but you started to mention a little bit about the social determinants of health that might influence why folks who identify as Black or African American and Latino heritage experience Alzheimer's disease. And I noticed, and whenever this is talked about, it's all, many of the factors are identified are individual factors. What is being done in research, or how are structural or systemic factors looked at? I know you mentioned medical care, but sometimes, and we saw this with COVID, it doesn't matter the level of education or the level of income in the ways that people of diverse ethnic backgrounds are treated, particularly people of color. So we saw that whether the person had lower economic status or higher economic status or was highly educated, they still receive certain levels of care. And I'm wondering, what other ways? So for example, if people experience obesity or people experience cardiovascular conditions,
like hypertension,
what stress factors and hypertension, what stress factors in society are contributing to those conditions that we're not addressing that might still lead to that? So
I think that's a fascinating question. I'd have to look and see if anybody is actually researching those. We know that stress can be a factor in developing dementia, and that we know that stress management in some studies show that if people who practice stress management or practice prayer or do something that releases or not releases, reduces stress, seems to reduce the risk. And I think that we can safely say that being part of a racial or ethnic group that is discriminated against, that systemic, institutional discrimination is stressful, and we know that. We've seen studies, and I've seen studies about that. And so I think that it's a fascinating area. I think there are also issues around, as I mentioned before, access to care, and management of those other controllable factors like hypertension, like obesity, like blood sugar, because we also know that there is a relationship between high blood sugar and high, and diabetes and Alzheimer's disease and dementia. So I think you bring up an excellent point. Thank you.
Thank you, because I was just thinking that stress, the way folks manage stress could contribute to obesity, could contribute to some of the other health conditions that are also risk factors for that. So
right.
Thank you.
It's all connected, isn't it? It really is all connected. Good question. Thank you. I just, okay. Um, so let me get back to this slide, which just is a reminder that individuals who are diagnosed or experiencing the symptoms of Alzheimer's disease or other dementias, that it is not an all or nothing kind of situation, that there is I like to think of it as a dimmer switch, not an off-on switch, and that there are going to be times during the day, or perhaps during the week, that individuals are going to be functioning at a higher, brighter, more connected level, and others where they're a little foggier, a little more confused, a little more disoriented. And that's important. It also has some implications in terms of their ability to do things like legal and financial planning, sign a durable power of attorney or a healthcare proxy, all of those things. So I think it's an important thing to keep in mind when you are looking at this. And there is a very strong movement, and we were part of this many years ago when we started allowing people with early stage, not early onset necessarily, some were early onset, but early stage, to kind of speak their truth and share their experience. And we did the first session of that back in 1993 it was. And it was a really kind of groundbreaking moment when you heard the voice of people with Alzheimer's disease. And so, we're trying to highlight that it's also, having a diagnosis of Alzheimer's disease doesn't rob you of your agency and of your sense of self and who you are. And there's still an opportunity for people to participate and engage and have a certain quality of life. I think that's a very important message and very counter to what the overall societal message is. Once you're diagnosed, that's it, goodbye. Your worth, your self-worth is diminished. So, however, this is, as you know, a progressive disease. And so it starts with that mild cognitive impairment stage. It actually starts with that preclinical stage. But once you start with MCI and then move to early stage, which on average is 1 to 5 years, middle stages can be 2 to 10 years, and late stage can be 1 to 7 or more years. So it's a long time to live with an illness, and it's a long time for a family to have to deal with it. So if you're dealing with something that is minimum 4 years, although it's very rare that it's that, and more like it's 15 to 20 years, that's a very long trajectory to forecast. Now, MCI, just so that you're familiar with it, is MCI is a diagnosis where the individual is experiencing problems with their memory and thinking, but generally it's subjective. It's not really that noticeable by others. There is something called subjective cognitive impairment, but that's kind of prior to mild cognitive impairment. It's not commonly used. And here, the symptoms are not severe enough to interfere with the individual's ability to live or function independently, and it increases the risk of developing Alzheimer's, although not everybody with MCI develops Alzheimer's, and not everybody with MCI progresses. Actually, and some people actually continue to move on. Let me just, I did see a question here, a couple of other questions. So any tests for early detection of dementia? Yes, there are tests in terms of psychometric tests, and there are some now tests that can show whether there is amyloid, beta amyloid in the blood. So those are not in common use, but I think will be more commonly used. And then there are some imaging tests that can be used, but unfortunately, those often are not covered by Medicare. So it's an issue. There's another question here from Brian. Is there a relation to dementia as a result of TBI? Yes, there is. And so actually there is a traumatic brain injury or a fall with a loss of consciousness actually is a risk factor for developing dementia later on. And Celine from New York City Aging, formerly DIFTA, it's now New York City Aging, have deep breathing exercises or morning evening meditation been shown to manage the disease somewhat. There is some fascinating work, and we participated in several workshops here several years ago, both using mindfulness meditation programs, teaching mindfulness to family caregivers to help them manage their stress. And that was shown to be, and there are several studies that show that these techniques are very effective and for people with the disease. And especially to combat some of the agitation and the anxiety that, yes, there has been, several studies that show that the use of meditation, deep breathing, and mindfulness techniques are effective. And I think we're going to see more programs that will be offering those. So good questions. Thank you all. So as the disease progresses to early stage, here the short-term memory loss is quite apparent. There is more confusion in orientation to place and time, not so much confusion related to person. They recognize most people in their circle, in their family, and in their community. There's growing difficulty with following complex instructions, learning a new gadget, learning a new remote perhaps, or a new microwave, problems with complex thinking, financial management, handling, how do I make it, how can I figure out a tip? I used to I co-led for 10 years or so, a support group for individuals with early stage. And it was a great group. And they formed friendships, and two of the women used to go out to lunch together and come back to the group and report that they were, and they were able to laugh at it, thank goodness, and say that neither of us could figure out the tip, but together they kind of did it together. And so, financial management, managing daily money management transactions is a real challenge for that person who is experiencing the early stage of Alzheimer's disease. The other thing that we see is more kind of an apathy, a lack of initiative and motivation to do activities. It's not that they're not interested, and it's not depression, although depression is something that we always have to rule out and identify and treat it if it's being experienced, because individuals with early stage can certainly have a reactive depression to the changes in how they're thinking. But this is different. It's more of this loss of initiative. So if somebody is there to help them with the planning and get things started, they can enjoy and participate and get very engaged and enjoy the socialization. They have difficulty performing usual tasks. I remember somebody reporting to me that he had gone to a home visit with one of our early stage people. She was actually moving more into middle stage, and he saw that there were several kind of cups of tea in various states of preparedness. And she just lost track that she was making a cup of tea, and she started, boiling water for another cup of tea. And there were, just so sequential kinds of activities are particularly challenging for people with Alzheimer's disease. And learning new things becomes difficult, learning new routines, new routes, new people who are in their lives, and showing poor judgment, walking out in very cold weather or rainy weather without an umbrella or without a coat. And some of the considerations for those in the early stage is that they still have the ability to understand the implications of their illness, and they can participate in decision making, and it's a good idea to engage them in decision making, especially about planning for care. And there are tools that we are now using, and we have programs that help people plan with their caregiver, so that the caregiver can hear it from that individual. And they can certainly identify and articulate their feelings. And again, often the person in the early stage is living independently, but is going to need progressive amounts of support and in order to keep them safe. And there are concerns here is to maintain their autonomy, maintain their sense of self-esteem, not take over for them, not be paternalistic, and to maintain their dignity. As the disease progresses into the middle stage, here there is increased memory loss and confusion, more kind of fogginess, difficulty thinking logically and organizing their thoughts and activities, confabulation, which is kind of making up statements to kind of fill in the gaps, problems with recognition for individuals in their circle, in their community, not so much for self. Again, they pretty much recognize themselves. They have increased challenges with language and communication. There might be greater, more extreme mood swings and changes, more disinhibition, more hallucinations and delusions. The hallucinations, by the way, are almost always visual, not auditory. It's not different kind of hallucination from somebody who is schizophrenic, who is hearing voices and telling them to do things. Most often the hallucinations are, I remember somebody in my early stage group would talk about seeing little men on her television set at night. And she wasn't at all disturbed by it. She actually enjoyed the visitors. She felt less lonely. There are some times where the hallucinations are distressing, like, who let that dog in here? I don't want a dog in my apartment. There also sometimes is difficulty with recognizing who is in the mirror, or being scared by that person in the mirror. Or when I ran the very first adult day program for individuals with dementia in New York City at a place called ICD, the International Center for the Disabled. And I remember one of my participants who used to go into the bathroom and have a lovely conversation with that woman in the mirror. And she would kind of slide the medicine cabinet mirror back and forth, trying to figure out where is that person. And I would go in with her and, say, who is that? She, oh, that's my sister. And she would have a lovely conversation with her. So it wasn't distressing. If something's not distressing, you don't have to treat it. What can be distressing is sundowning. And those of you who either work in residential care or visiting family, visiting individuals in their homes, might see that in late afternoon and early evening, there is increased restlessness, agitation, anxiety, sometimes even to the state of looking like psychotic symptoms. That needs to be treated, although we now know that some of the approaches that we have adopted here in New York comes from our palliative care approach, have greatly reduced the symptoms of sundowning, which we'll talk about what that approach is in a little bit. And there might be more, increased motor problems, motor planning. If you ever ask somebody who's in the middle stage to get into a car, they don't know where to put, they need really sometimes very clear verbal and physical guidance about where to put their body. And there's beginning incontinence, but I would argue that it's not true incontinence. It's rather they're not responding quickly enough to the signal to void, and that they're having difficulty with the mechanics of toileting. And so they're not sure about how to, undress or where to do it appropriately. So they need more support. And I think we can avoid or forestall the true incontinence that comes with very advanced disease until later on in the disease. And then, of course, the issue of wandering and getting lost. And that's something that we've addressed at Caring Kind with a program that I created back in 1990 called the Wanderer Safety Program, Medical Alert Wanderer Safety Program, because it's always life-threatening. Okay. Here, the middle stage considerations are that we want the individual to participate in activities that are appropriate for them, that have been modified. They can still make choices. They might not be able to independently state what it is they want, but given a choice between, do you want to, play cards, or would you like to do, a drawing, or do you want to knit, work on your knitting project, or whatever it might be. So they can make choices. And here the concern is dealing with their frustration, their fear of abandonment. And you see often that family caregivers report that the individual does not leave them alone, that it feels like they're Velcroed to them, what we call the wallpaper syndrome. They're just like, they're stuck on them. Here, the individual is no longer able to live alone safely. So you need either a family caregiver there, or you need paid home care or residential care to keep them safe. Oops, why isn't this progressing? Okay. In the late stage, here the individual has lost most of their verbal communication. There might be some babbling. There might be some calling out. Mama, 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 or help me, help me. They might still be able to sing. There might be minimal recognition of themselves in the mirror or of family members. Here, the individual might be less ambulatory, more sedentary, and eventually bedbound. However, I think that if people are put on a program of supervised walking and keeping them strong, you can actually keep people ambulatory a little bit longer than you believe. Here, there are difficulties with eating. They have difficulty using utensils, so you want to use more finger foods, and you want to deal with issues of swallowing challenges, and maybe using some thickened liquids. You want to make sure that there's adequate nutrition. And here there might be total incontinence of bowel and bladder, and there is no capacity for self-care. They are totally dependent on somebody else for all of their activities of daily living. Not that you still might be able to put a toothbrush in their hand and start them with a toothbrushing moment, and they might be able to continue. But as the disease progresses, that diminishes. So really, it is a time for superb nursing care and good nursing care. And that can be done at home. It is a huge burden, I think, for family members to do this. And remember how many years they've been caring. And remember that many of the caregivers themselves are older adults and have to deal with their own issues. So our late stage considerations are, remember that the individual does retain abilities. So there's still some sensory ability. They can respond to music, to talk, to touch, to massage, to good aromatherapy. And our concerns here are maintaining comfort, maintaining dignity, and using the palliative approach to care, which I'll talk to you about a little bit, kind of what those elements are. So before I move on to the different kinds of illnesses, any questions about the stages or the symptoms? And as you can see, that it's a lot for families to consider. And I recognize that probably half of you, if not more, either have been or have a family member. Yes, Celine, I see. Who you are caring for, and this might be a lot more information than you bargained for. And so, I always encourage people to kind of be prepared for the future, but don't live there. Stay in the present, and enjoy what you can with your relative with the disease, now. And remember that there's so many strengths that are left. So Celine, you had a question? You can go off mute. Oops. Celine, there you are. Did you have a question, Celine? Yeah, you're on mute. Hold on. Let me just. Yeah, I think you're still on mute. Okay. Yeah, we'll talk about home care hours in a little bit, Oksana. Celine, I'm still having trouble hearing you. I don't know why. Maybe we'll put it in chat. Okay, yeah, type here. That'd be good. Yeah, there certainly are. Let me just answer the home care hours. That if somebody is on Medicaid, that we actually still can get 24-hour care or even split shift care, either through Medicaid itself or through the nursing home diversion and transition waiver. Okay. Question is, how popular is it for individuals to get the early test just to know if they will end up getting AD? I think it's highly individual. And I just read a paper about kind of what happens when people know that they might have the genetic profile that puts them at greater risk for developing the disease. I think it's, I think a lot of it has to do with your own kind of risk tolerance or knowing what you're going to do with that information. And I think now that we're at this point where we actually have drugs that can not only manage the symptoms, as we'll talk about in a few minutes, but have the ability to slow down the progression and are disease modifying drugs, I think we're going to see more people who want to do this. And now we're also finding that there have been studies that show that people who manage their risk factors, the study that was done at New York Presbyterian at Weill Cornell with the Dr. Richard Isaacson showed that individuals who went through a personalized care plan, people who were at risk for developing Alzheimer's disease because of a family history or because of other various risk factors, that about a third of those individuals could show that they were going to reduce their risk by following certain diets, exercise plans, sleep hygiene programs, stress reduction programs. So I think as the field develops and as we have more ways of treating it, I think you're going to see more people wanting to know what is their genetic profile that might put them at greater risk, or what are the other issues that might indicate that they might be at risk for the disease. So the problem is that there are not enough neurologists. There are not enough geriatricians. There are not enough people who are around, people who are looking now to get a diagnostic evaluation at one of the major diagnostic centers in New York have to wait sometimes up to 6 months to see a physician. That's a very long time in the life of somebody with Alzheimer's disease or potential Alzheimer's. So it's an issue. Okay. Now let me see. Now Rosie from MJHS says, I know someone who repeats things. As an example, may tell you she's still able to do things on her own, just a matter of remembering things. She says, what stage can this be in category? And it's hard to categorize, and it might not be dementia. It might be some kind of amnestic disorder. It might be a dementia. And it might just be, if she's able to function, I would say that it probably needs to be more towards MCI, or it's hard to say. And I think, you would want that individual to be evaluated at a major diagnostic center, or start with her own physician and refer to a neurologist if possible. Yeah. So let's move on. So just want to go over so we have another hour. Just what are the common other dementing illnesses? So dementia with Lewy body is second most common cause of dementia, although some people think vascular is. And here the memory and thinking problems are similar to Alzheimer's, but here they have symptoms that look like Parkinson's. There might be tremors, there might be muscle rigidity, there might be kind of the pill rolling kinds of things that happen with the hands. And there might be some changes in sleep and restless leg syndrome, visual hallucinations. So yeah. On in vascular dementia here, there occurs as a result of certain injury to the brain, often on a microscopic level, and the location of the brain injury determines how the individual's thinking and physical functioning are affected, but initial symptoms often include impaired judgment or ability to plan. FTD, frontotemporal degeneration, is a highly complex disease. There are multiple variants. I'm not going to go into all of them. It's important to note that people with ALS can also develop FTD. And here the symptoms include changes, pretty extreme, I would say, changes in personality and behavior, and difficulty with language. So there's one form that's a primary progressive aphasia. So there is change in how they express themselves or understand language. Apathy, disinhibition, more impulsive, hypersexual, making inappropriate sexual comments to a colleague or somebody on the street, hyperorality, constantly putting candy or smoking. They need to have something in their mouth, making very poor and dangerous financial decisions, sometimes stealing or taking things. And there's no lack of insight into their behavior. And there's no emotional concern about how this is affecting their family member. And often all of this is combined with poor personal hygiene. FTD is a very challenging dementia. And generally symptoms develop at a younger age and the progression is more rapid. Affects men and women equally, although in my experience, I've seen more men with FTD. And there are estimated 60,000 cases in the United States. Diagnosis takes longer because often people are presumed to have some psychiatric disability or diagnosis. So it can take over 3.5 years to get diagnosed. And the implications for families. And if you want more information, the AFTD, the Association for Frontotemporal Degeneration, has some wonderful information on their website, and they have some really, really moving videos. So we work in partnership with the Lewy body dementia group and with FTD as well. Our programs are available for people with any kind of dementia, Alzheimer's and other kinds of dementia. So now, whoops, one more chat. How many years or decades are we from? I have no idea. I've been in this field forever, and they keep saying the next 5 years. Well, we're at a tipping point at the moment because the 2 new drugs have been approved in the last 2 years. So, and this is it's been 18 years since we've had a new drug approved. So we're making progress. An all-out cure, I'm not sure that we'll ever get to an all-out cure. The brain is so complicated. I think we can come up with a way that I think we will come up with, and we are coming up with ways to slow down the progression or delay the onset. And so if we can delay the onset by 5 years, we can cut the incidence in half. If we can delay the onset by 10 years, we can almost eradicate the disease. So interesting question, but not sure that that it actually, we're gonna get there. So let's talk about medication. So the medication pictures are what I always call a good news, not so good news situation. So until really earlier this month, but the fact that the good news is that we have medications. The not so good news is that the majority of the accessible medications are not that good. They're better than nothing. They do manage the symptoms, but they don't modify the disease. So the most common is Aricept, which is available generically as donepezil, and there are two others, Exelon and Razodine, and then there's one called Namenda that works on another pathway, and then there's one that combines Aricept and donepezil and Namenda together, and that seems to have a synergistic effect. I've heard anywhere from, maybe 20%, 30% of people who take these drugs will see a significant benefit. Often you're not going to see a benefit, but if you take them off the drug, they're going to rapidly decline. So it's doing something that it might not be as overtly apparent to the individual and their family members. So, but this is currently what's available and what's covered by CMS, by Medicare. Now, the good news is that last year, well, now 2 years ago, June 7th, 2021, the first new drug was approved in 18 years. It is the first disease-modifying drug that got approval by the FDA. It was a very controversial approval. I'm not going to go into all the controversy, but there was a lot of controversy around this. And it was approved under what's called an accelerated approval. This is important because it determines how Medicare is going to CMS decided how they're going to cover the drug and make it available to Medicare recipients. So another important thing to think about is that Aduhelm, which is the new drug 2 years ago, can cause serious side effects, including amyloid-related imaging abnormalities, or ARIA. So remember that term, ARIA. So it can either be edema, it can be swelling in the brain, or it can be hemorrhaging or slight bleeding in the brain. Most often, there are not any symptoms that are really serious, but they can be serious. So you have to monitor for this brain side effect, this amyloid-related imaging abnormality, or ARIA. So remember that term. Now, CMS in April of last year said that they will cover this new drug, this new class of drugs. Actually, these are monoclonal antibodies, anti-amyloid monoclonal antibodies, that they will cover them only under CED. I hate to get into the weeds, but this is important stuff. The coverage with evidence development, meaning that you have to be in a research trial. They're saying, under accelerated approval, they're saying, I don't need to see really, strong clinical benefits. I need to show that it removes amyloid and that meets that endpoint. And so the other thing is that this has to be for people who are either MCI or mild AD, early Alzheimer's dementia. They have to enroll in a CMS-approved trial or trials supported by the National Institute of Health. Greatly restricts access. So basically, Aduhelm, unless you can afford $28,000 a year, you're not going to be able to get it. And it is an infusion. You have to go to a site to get the medication. It's not like you're given a pill. And so there was a lot of discussion about whether this is discriminatory against African Americans and Latinos, because we all know that African Americans and Latinos do not participate in research as a whole, and certainly not in Alzheimer's research. And CMS said that any new drug that comes up after April 22, that if it's a monoclonal antibodies directed against amyloid, it will be covered, but it has to be under CED. They have to be in a registry and they have to be in a trial. So, oh, we didn't change that color. Okay, so lecanemab Yay, beginning of this year. Very exciting. The FDA approved this under accelerated approval. And again, so that means, that there's a biological effect. We were able to show significant reduction of amyloid in the brain. That's really great. However, in other studies, when you reduce the amyloid in the brain, there was not a significant clinical benefit. There was not an improvement in memory, cognition, functioning, quality of life. They have applied for Eisai is the drug company that is came up with this drug, has applied for traditional approval. Interesting findings. So they have shown that it has slowed the rate of cognitive decline by 27% over 18 months. That's significant, we think, in terms of the life of individuals. Slowed the rate of functional decline by 37% and projected to delay progression to the next stage by 2.5 to 3 years. That buys somebody 2.5, 3 years where they can function more independently and enjoy a certain quality of life. That's really exciting. The next question, by the way, the drug is called Leqembi. The brand name is Leqembi. And again, it's indicated for those people only in those categories of MCI or early stage. Again, it's an infusion every 2 weeks. You need an MRI needed before treatment and multiple times during treatment to detect ARIA. Remember ARIA. And again, ARIA is one of the major adverse effects, as well as infusion-related reactions like fever or flu-like symptoms. Mostly, these are mild. And there are special considerations for those on blood thinners. Some of you might have read about an individual who died who was in the trial, but she apparently was on certain blood thinners. So now, before I move on to the next screen, let me just see here. Okay, yeah, okay. Special consideration for those on blood thinners. Yes. So now there are new drugs, other monoclonal antibodies like Aduhelm and like lecanemab. MAB means monoclonal antibody. Donanemab will be coming up, we hope, in the next 6 months with some information. Gantenerumab, which actually was not an infusion, but was a subcutaneous injection, much easier to administer, but didn't really meet their endpoints. I would say it was more of a negative finding, not a failure. We learned a lot from that study with gantenerumab. And then crenezumab, which is a similar drug, did not slow or prevent cognitive decline in people with a specific genetic mutation, which causes early onset Alzheimer's disease. This is in that population in a community in Colombia in South America. We might have heard or seen stories. 60 Minutes, I think, did a pretty big story on it, about this group of families where there was this very strong familial Alzheimer's. So, okay, now before we move on to my next topic, any other questions about the drugs? So this is, it's a great time to take this presentation, because we're talking about, we're on the cusp of the ability to have a treatment for early onset, early Alzheimer's, early, MCI and early stage, where we can buy people significant amounts of time, which is really exciting. Yep. Okay, thank you for that. So, yeah, it's really, I frankly, it was, and we've seen so many disappointments. This was really exciting. There are a lot of challenges. There are a lot of challenges about making sure that doctors know how to prescribe it and who's the best client for it. What are the things you need to watch out for? And the issue, again, of having enough individuals who can do the diagnosis and then enough infusion sites. Okay. Now, this is a disease that affects certainly the individual who's experiencing all of these changes and all of this difficulty. But our concerns here at Caring Kind are very much for, and have historically always been for, the caregiver, and recognizing that caregivers are an integral part of the care system. And frankly, our whole health economic system would crumble if it were not for family caregivers. Most dementia caregivers perform very complex tasks, managing the finances, communicating with medical and pharmaceutical staff, advocating on behalf of the care recipient. 51% of dementia caregivers provide medical or nursing tasks without prior preparation. Shocking. And healthcare providers ask Alzheimer's caregivers about their needs in 25% of cases, and the needs of the care recipient in only 46% of cases. So you see that the caregivers are kind of overlooked in the system, and I don't think they are recognizing. There's more and more recognition of the importance of and the need for caregiver support, because we need to, I always say to caregivers that, self-care is not selfish, that you need to take care. You need to really prioritize yourself first, because if you don't, then who's going to care for your relative? Now we know there are multiple effects on caregivers, especially Alzheimer's caregiving and dementia caregiving. There are the emotional responses. We know that there's greater rates of clinical depression, more anxiety, more social isolation, greater rates of stress when compared to other caregivers, more what we call this grief response. So at the very core of what we do with our work with caregivers is kind of recognize that they are losing that relationship, or the relationship is changing and it feels like a loss. And often they are stuck in this kind of frozen grief. And we did a program a couple of years ago with Dr. Pauline Boss, who wrote a book on anticipatory grief, or I'm sorry, not anticipatory, but ambiguous grief, and anticipatory grief, actually, both. Recognizing that that individual is there, but not there in the same way. And there's a lot of challenges with that. And then COVID hitting, and for the past almost 3 years now, well, it is 3 years, the isolation and the change in routine and the trauma of living through COVID, I think has only exacerbated the stress and the isolation and the loneliness. So, and often, as I write here, comparing PWD, this person with dementia, with their former self is very painful and very hard. We also know that it's not just the emotional impact, but that there is a physical, medical impact. Much more exhaustion, physical exhaustion, reduced immune function, more cases of new hypertension and new heart disease in caregivers, more doctor visits. Caregivers, dementia caregivers are more likely to report that their health is fair or poor, and more emergency room visits and hospitalization. Older spousal caregivers might predecease the person with dementia themselves. And spousal caregivers, interestingly, are at greater risk for dementia themselves. Somebody mentioned stress earlier. I think that might well be related to the ongoing stress. And when you're experiencing stress, your cortisol levels remain high, and there's no relief from that. I remember, often there is family conflict about best way to care for mom or dad or whomever. And I remember a caregiver saying to me that he felt like he was picked up by a tornado and thrown around by this disease, never knowing where he was going to land. And then you have the basic concern about, how am I going to pay for care? Care is expensive. Even accessing this healthcare, these new drugs, the new cost for lecanemab is $26,000 a year. And certainly the drug companies will offer some assistance, but we don't know yet what CMS is going to do. So anyway, really worried about finances. And, but the contribution of unpaid care, family care for people with Alzheimer's and other dementias is an estimated value of over $257 billion, and over 11 million Americans provide unpaid care for people with Alzheimer's and other dementias. Now, Mother Teresa, who you mostly all remember, said, "God doesn't give us more than we can handle. Sometimes I wish God didn't have so much confidence in me." And I will tell you, I have spoken to caregivers who feel very much like this. And I remember one caregiver who'd been caring for her husband for a while, and she said, "God forgive me, but every morning before I wake up, I kind of say a little prayer and hope that my husband has disappeared, because I'm not sure I can stand one more day of this." And, given the right supports, she was able to do it, and she was able to continue to care for him. But the stress and the strain and she was just, it was exhausting. So I think so many caregivers have this sentiment that sometimes I wish God didn't have so much confidence in me. There's another wonderful caregiver who wrote a book called 10,000 Joys and 10,000 Sorrows, a couple's journey through Alzheimer's. Olivia Ames Hobletzel, who is a Buddhist teacher, studied Eastern medicine, and wrote that she needs to live in two realities. She needs to live in her own reality and in her husband's reality, which is true. But she also recognized that she can let go and she can still love him at the same time. So there was that duality, and helping families come to that point where there can be that duality, I think is important. And it's a journey, and it takes a while. So, so we need to invest more in care. And I know that hopefully there'll be a National Family Caregiver Act, and ways of supporting caregivers across this country. We're pretty fortunate here in New York. New York State has invested a lot in Alzheimer's care and support. Governor Cuomo was the initial creator of the Alzheimer's program. We've been a beneficiary of that and created programs under those state dollars with many of our colleagues, and certainly Sunnyside. I know there's somebody from Sunnyside here. They participate, and so does PSS and NYU and many, many other organizations. So New York State has done pretty well, but we need to do better. But currently, federally, for every dollar we spend on research, we're spending $261 on care through Medicare or Medicaid. And the cost of dementia care will exceed $1 trillion by 2050. So there's a lot going on there. I'm going to move on from this and what you can do. So as professionals in the field, I think it's important for you to be familiar with the resources of your own organization in terms of dementia care and dementia care for the caregiver and caregiver support programs, but also what we do here at Caring Kind and how we can partner with you. But also encouraging early diagnosis. So if you have somebody that you're suspicious about, and it's best for them to get that diagnostic evaluation and get an idea of what's going on. Maybe they can be treated with some of even the current symptom managing medications. And then assisting somebody with kind of the long-term plan. Long-term care planning, which again is so difficult in our system here in the United States, and helping them with the legal and financial planning. Who's going to manage their daily, accounts and their bills and their taxes and stuff when they can no longer do it, and to help them engage and create a support system, and whether that's with family, friends, with a faith-based organization, and certainly to support the quality of life and promote the sense of purpose and meaning for the person with dementia and their care partner. Now, I want to take a few minutes to talk to you about Caring Kind. I know most of you all signed up through the helpline, so you have that number. That's a really important number. That number is answered in English and Spanish. We have Chinese speaking staff here, Mandarin and Cantonese. And we have a translation line that goes into 200 different languages. So we can really help anybody. So these are our programs. And I will, oops, let me see, there's a chat question. We do, I used to have a Russian speaking staff member, several, I don't at the moment. But we can provide work with Russian speaking clients through our translation line. So we are, by the way, interested. We are looking for an African-American outreach social worker. Our African-American outreach manager, who'd been here for many years, retired. And we're also looking to expand the number of Spanish-speaking clients as well, staff as well in the social work area. So hold on. There we are. Okay. So we are, I like to say, New York City's trusted partner in dementia care. We've been here for over 40 years create deep roots in New York City. All of our services are free of charge to the individual with dementia and their family caregiver. And we collaborate and work with many of the organizations like DeRote, like SAGE, like MJHS, that are on the call today. And I'm so delighted that you're here. We cannot do this work alone. So our role is really increasing community awareness about, not only about the disease, but about the resources that are available for family caregivers and for individuals with the disease. And we provide direct service. So I like to think for that client and that family, we are a roadmap to care and a pathway to hope. There's such a pervasive feeling of helplessness and hopelessness around this disease. And yet we've learned so much about how we can care for that individual, improve their quality of life, and help family members go through this, through our variety of programs that I'm going to talk to you about now. Our role is very much around education and training in programs like this one, and we have developed model programs over the years, many model programs. The entry point, the really important entry point, is that helpline, 646-744-2900, so that an individual can talk with a caring professional about concerns. And this helpline is available to you as well, to other professionals in the field. So if you're dealing with a behavioral issue or a particularly challenging issue around entitlements or getting home care. There was a question earlier about increasing home care hours. And there are ways that we can do that. And our staff is really good, and we work with other partners like New York Legal Assistance Group and Valerie Bogart and others who you might know very well. So we really does take a village. And our goal is really to help that caller understand more about the disease, more about Alzheimer's, but to get connected, realize that there are resources and that there are supports out there for them. And so I encourage you to, use that number liberally and give that to your clients. This is back in the days when we actually had a full staff in the office, this is what the helpline looked like. We are now on a hybrid schedule, so most staff are working 2 or 3 days a week in the office and 2 or 3 days a week at home. So our social work services, we have short-term counseling and support for individuals and families by licensed MSWs. Yes, we do the usual long-term care and Medicaid planning and paying for care. Again, these are complex systems. But we also can provide family conflict assistance, and we work with several mediation organizations and can refer to those. We provide assistance to help that long-distance caregiver who is working with a caregiver here. Mom lives in Brooklyn. One daughter lives in Brooklyn. The other one lives in Los Angeles. And so there might be, that daughter needs to know how she can be helpful. And we refer to and work collaboratively with many of the other caregiver support programs and community services, senior centers, or they're now called older adult centers. And day programs, social adult day programs, and other services, home care, and other community services that are available. And then we have, and I hesitate to say this, but we we do have some limited financial assistance programs. So if there is a specific need for families, you can contact the helpline and talk to somebody about applying for a modest grant. These are not ongoing grants, they're one-time grants to help meet a specific need. And there has to be a long-term plan in place. So, but we can do that. Okay, oops, let's see. Oh, great, okay. Message from Diana. Okay, great. Thank you. Now do we offer free Medicaid applications for clients? We will help. We have two seminars. One is on Medicaid for home care, where we will help families understand what is the process, and we can, work with community-based agencies that help families, fill out the Medicaid form itself. And our social workers can help with that kind of service, I think to a limited extent, I would say. But we can do that. So as I said, we do have some, special assistance funds that might be helpful to some of your clients. And again, this is limited to people with dementia. So our support group programs, I would say we now have probably 85 to 90 groups in all 5 boroughs. Some are specialty groups, some specifically for adult spouses, for adult daughters, for children, adult children. And we have groups in different cultural and language. We have 4 groups, I believe now, for Chinese-speaking families. And we have been working with SAGE. I don't know, I started working with SAGE in 1993, where we created the very first support group for individuals who were LGBT. Actually, at that point, it was just LGB. And that's been a wonderful partnership. So we are, the support groups, and I like to think our groups are a little bit different from the other models out there. Our groups meet minimally twice, every other week, twice a month. Many meet weekly. There are 1 or 2 that meet, monthly. I think our Chinese groups only meet monthly because it's kind of an unusual format within the Chinese community. That our groups are all professionally, the leaders are trained and supervised, so they come to a monthly supervision. So if you are interested in becoming a support group leader, just contact the helpline at 646-744-2900 and ask to speak to Suzanne, who is our support group manager. And she actually is the director of all of our support services. And so, you can learn more about the training that's happening. We also do have a group where we're developing a group for people with early stage as well. Groups are, I like to think, as the keystone of our services. They provide a safe, welcoming environment to deal with the issues of being a caregiver, and we'll get that very profound insight that they are not alone. Let me check the chat again. Oh, great. Okay, good. Yes, and New York Connects actually helps fill out Medicaid applications. Thank you, Stephanie. And yeah. Yeah, the special assistance funds, there's a question about those here. Sometimes it's used to, somebody wants to go to an adult day program, they're not on Medicaid yet, can't afford the sliding scale of, let's say, 45 to 50 or even $80 a day. We can provide a modest grant of, maybe $800 or $1,000 to get them, so that family can get some relief while they work with a social worker or an agency to get Medicaid in place, and then they can continue. Medicaid will pick up the social adult day program. that's often what our financial assistance grants are used for. It has to be a situation where it's not ongoing, but there is an end goal in place in terms of a long-term care plan. So our support groups, as I said, this gentleman was a member of our support group for over 10 years, cared for his wife for many, many years. He was still working in his 80s. Lovely, lovely guy. And he wrote something for our newsletter, said that in the support group, it preserved his sanity, countered aloneness and despair. The only place he could openly express his pain, loss, and anger, gaining valuable insights and direction. It was really, very meaningful. And I think that the connections that are made in the support group are really, really important. This is one of our support group rooms. Now all of our groups are virtual. Some of them are beginning to come back in-house and in person or in a hybrid setting. So I'm delighted to see that. But as you can see, it's a warm, welcoming, lovely space in our office Midtown. We have a whole variety of education and training programs. We do legal and financial seminars. We do this Understanding Dementia meeting in a slightly different format for family caregivers. It's, which I think might be helpful for some of your clients. As I mentioned, we do a Medicaid home care seminar that's led by an elder law attorney. So is the legal and financial planning seminar, Monday night education meetings with various topics. Like we just did one on kind of dealing with guilt and anger in caregiving. And then we have a variety of other topics, but then we also do more in-depth training. So we do a dementia care training for professionals, our family caregiver workshops. We do family caregiver workshops and a dementia care training for professionals, for direct care workers as well. We also do some coaching, and we do some work with some of the private assisted livings and others who will pay us to provide some training and ongoing coaching for their staff. This is our training center. So hopefully we will be really post-COVID at some point in the near future. And so it's a lovely space. This is a project that actually where the aides that we've trained, people who are looking for private home care, we've set up a system where they can access a website called togetherwecare.com. Family members can look for trained home care workers. They have to take on the responsibility of vetting them and setting up the employment arrangement and all of that. It's independent of us, other than that we have trained the home care workers. This program is really essential. So if you are working with people who are memory impaired, every person who is memory impaired should be wearing this identification bracelet. We partner with Medical Alert to do this. We have for many, many years. This is a program that I developed, my very first project, actually, when I started working here in April of 1990. And it's a program that identifies people who are at risk of wandering. And there is we know that 50% of people with dementia will suffer severe injury or death if not recovered within 24 hours. There's a national safety registration program. We provide ID bracelets for people with dementia and their caregivers. Remember, they are older adults as well. So if they have a heart attack or a medical emergency and are taken to the ER, ER staff can contact Medical Alert, that number, and say, I need somebody to help take care of Mr. Jones because Mrs. Jones is in the ER. She's not going to get out anytime soon. We also have a very proactive system where we fax or email, mostly email now, a bulletin to hospitals, shelters, EMS, police precincts, transit and medical examiners' offices when a person is discovered to be lost. We have a long-standing relationship with NYPD, and the media has been very helpful to us. And we support families during the incident. So at our height, pre-COVID, we were registering, I would say, close to 1,000 clients every year. I would say it's probably maybe half of that now, thanks to COVID. It's just we can't get out to do the outreach that we used to do. We have a whole set of interesting conferences and meetings that we do. We just did a research update on November 21st. We will be doing a meeting on caregiving, hopefully in the spring, and our palliative care seminars and our brain health awareness programs that we just did. We do in the Chinese community and the African American and Latino community, the importance of maintaining good brain health and recognizing Alzheimer's. So Connect to Culture is a program where we work with the cultural institutions in New York City, both museums, horticultural institutions, botanical gardens, libraries, performing arts organizations like Lincoln Center, Orpheus Chamber Orchestra, New York Pops, and make those programs accessible to families with dementia. And they're a great resource. And so we're working with Arts and Minds and the Studio Museum in Harlem and the Brooklyn Museum, and so many, many others. It's really an exciting, wonderful program. And now many of these programs are online because people are not going to these things in person. At least many of our clients aren't, because they're still, terrified of COVID and not wrongly. So I encourage you to look at our website, Caring Kind NYC, and then look at the Connected Culture programs there. Okay, as I mentioned, we have been very invested in diversity and inclusion efforts to bring our programs and services to culturally diverse populations, including the African American, Latino, Chinese, LGBT, and most recently the Orthodox Jewish community, especially in Brooklyn. So I've been working for many, many years with the Orthodox community kind of undercover. And most recently we got some funding from the Sephardic Foundation to hire, we now have 2 full-time Jewish outreach social workers who are providing services to that community. Many of the individuals in that community, the elders, are Holocaust survivors from their early life, and dementia and dementia management is made so much more complicated by that Holocaust experience. Trying to get somebody into shower, or when a police car comes by or an ambulance with a siren, it can trigger all kinds of terrifying, really terrifying trauma. So it's been very interesting and really important work. We have a lot of linguistically appropriate materials in Spanish and Chinese, and some other languages as well. And this is one of our programs pre-COVID, because nobody's wearing a mask. We had about 400 clients, individuals with our, and many, many community partners there in Chinatown at one of our Chinese brain health awareness programs. So I'm going to send you this form. This is our healthcare Caring Kind Connection form. So if you have clients who can benefit from participating in our programs, you can connect them by using this Caring Kind Connection form. The family caregiver just has to sign permission to you to give their name and contact information to us at Caring Kind, and then one of our dementia care specialists will contact the family and say, I heard from a social worker at XYZ and they thought, tell me what's going on. How can we help you? We will work in partnership with you. So, and we tried to do this with doctors. I find it works better with social workers and with nurses. But social workers are more, doctors are dealing with the medical issues. They're not dealing with the caregiving issues so much. So I'm not blaming them. It's just who they are. Thank you. Good question. A question about Dasha here. Okay. Dasha, oh, Dasha, yeah, Dasha is terrific. Dasha has left us, actually, unfortunately. Dasha was our support group coordinator for many years, and she's left us. I'm still in touch with her. And the Safe Return Wandering program, there is a fee for that program. If people cannot afford it, we have some money, thanks to City Council and some other philanthropy, that we can provide that free of charge. So, and it's, I'm not quite, I think it's under $100 to register. And then there is an annual fee with the wandering program to maintain the update the medical record. People remain in the registry if they don't do the annual fee, but we recommend they do. Okay. All right. Okay. And we just talked briefly about this project that we started over 10 years ago to bring this dementia-capable palliative care to New York City. We worked with 3 partner homes who are now accredited in Comfort Matters, and we worked with one public nursing home, which is Kohler, which is also now engaged in and accredited. I will say that there is, and I think it's online, our palliative care project. We did a series of seminars on dealing with pain in dementia care and the palliative care approach. So I think it's online and you can find it. But it's been a wonderful approach to care and reducing the behavioral symptoms of the disease and improving quality of life for individuals with the disease, and certainly for the staff who take care of them in residential care. I did want to mention that we're still, I can't believe it, still talking about COVID, but people with dementia are twice as likely to get infected. African Americans with Alzheimer's and related disorders are 3 times as likely to get infected, most likely due to this combination of pre-existing risk factors. And we know that there have been reports of greater stress for caregivers during COVID, special concerns for those who were locked out of residential care, and appropriately to make, to prevent infection. And as I said earlier, there was greater and more rapid decline for people with dementia. We participated in that survey. I'm going to move on here. Just want to mention a couple of other projects that we're involved with. We are a subcontractor to NYU Langone, the Engagement in Longevity in Medicine Research Collaborative. So part of our role is to encourage families to participate in health research, and specifically in dementia research. And working with NYU and with the department, with New York City Aging and Aging in New York Fund, that we are focusing on educating older adults about health and how to participate in clinical research and the importance of doing that. It's a project that's funded by NIA. And then the last 2 programs I'm going to mention to you are new programs. Our Memory Advocate Peer Program, which is piloting. We now have, I think, 4 clients who are enrolled. The goal is to connect recently diagnosed and early stage people living with dementia and their caregiver to connect them to an experienced mentor who was a former caregiver who's been trained about how to manage this relationship and volunteering their services. Goals are to provide emotional support, connect them to community resources, and educate about and facilitate participating in Alzheimer's disease research. Started by Jim and Jerry Taylor. Jerry was part of our early stage programs many years ago. Jim is a very strong advocate. And so we are now, so if you are interested in learning more about either if you have clients who are interested in becoming, if they're recently diagnosed and would like to be paired with a mentor, or if you have clients who were caregivers who might be interested in becoming a mentor, you can contact Marcia Henney at MHENNE@ckny.org. I think it should be cknyc.org, actually, cknyc.org. I'll change that. Okay. or you can call her at 744-2937, under 646. And this is just our MAP program at Caring Kind. And I do want to mention to you that we have a whole host of new early stage programs. So if you have clients who are in the early stages of the disease and looking for stimulation, looking for connection, looking for socialization, we have something called cognitive stimulation therapy, which is a wonderful program that meets twice a week for several weeks and then continues once a week on a maintenance program. This is all thanks to an ACL grant that we received. We're bringing new programs, bringing evidence-based training to family caregivers to build skills in behavioral symptom management and increase their knowledge and preparedness for ongoing dementia caregiving. And so I encourage you to call the helpline and ask to learn more about the early stage programs, or you can go online and you'll see information about the early stage programs and these other programs there as well. So lastly, we are privately supported to a great degree. We get very little money from government. We get some money from the state and some money from the city. So there are events that if you'd like to join us, we'd love to see you at our walks. Last year's walk was in Coney Island on the boardwalk, and in Central Park. We'll be at both locations again next year. We just had a kickoff for our Brooklyn walk was held at the Watermark in Brooklyn, in downtown Brooklyn. Brooklyn Heights, I think, is where it is. And then we also have a lot of athletic events. So if any of you are so athletically inclined and would like to run the marathon, we actually have several openings in our TD bike tour, which I believe is in May. So, you can contact the helpline at 646-7440 to get more information about that. And lastly, those are the questions. I'm going to stop sharing and we'll go. We have a few minutes left for questions. Thank you all for sticking it out. You're really terrific. It's a lot of information. There's Riverdale Senior Services. Thank you. Yes. Thank you, Brian. Let me remind you that you will be getting a questionnaire as well to see what we, see how we did. And any last comments or questions you can put in chat, or you can simply go off mute and ask. We have a few minutes left.
I'll come with mute, sorry. This is Diane Mack again. Thank you so much, Jed. I did put this in a comment individually to you, but now I have a chance to say it out loud. I thank you so much for the way in which you presented this workshop. As a professional and as a former recipient of some of your services, as a caregiver to a person who had dementia with Lewy bodies, your organization was phenomenal and very helpful for me. And so even as you were giving the presentation today, it sparked memories, and the way that you were giving it helped me continue to stay a part of it. And so what you and your staff do is tremendously helpful for us as professionals and for the people that receive your services as caregivers and the people they are caring for. So many comments were going through the chat as you were talking about the clinical trials, people of color, whether it was discriminatory or not. And one of the things that I'm doing or looking at how to approach this issue, I identify as Black, as African-American. I was severely affected by COVID. And one of the things that I decided was to participate in trials. And since I'm still in recovery in different ways. I have a relative that's contracted COVID for the 4th time, is to say to my community, we must participate, and why, and helping them understand the process, the value in every way. And so I've been partnering with NYU, glad to see that, and hosting these community workshops. I will be NYU Alzheimer's Dementia Research Center will be speaking about healthy brain aging on Tuesday, January 24th at 3 o'clock, and on COVID and cognition on March 28th. And afterwards, the Sleep Aware study, which specifically speaks to Black and African American members to participate in the Sleep Aware study about dementia.
Mhm.
And the Alzheimer's Dementia Research Unit will speak, encouraging people to become participants if they're eligible, and if they're not, to utilize these services which you talked about during this presentation. So if anyone is interested, I shared my email with you, and hopefully you will reach out to me and we can figure out how to share this with the people that's on this call, so we can spread the word and begin to help people process and talk about it. I'm on the call moderating and help facilitate the conversation so we could address concerns in the community.
Okay.
So I just wanted to share
Diane,
that.
send me that information and I will make sure it gets out to everybody who's on the call here.
I will do that.
Terrific. So you can send it to J. Levine. Here, I'll put my email here. J. Levine at cknyc.org. So just send that over and I'll make sure that Stephanie gets it on my end, and when we send out material tomorrow, it'll go.
Thank you.
Okay, thank you. Good. Anybody else? Any questions, comments? Okay. Well, thank you all for your attention. I am very pleased that everybody kind of stuck it out. That's great. So do keep in touch, and I'm going to give you back a couple of minutes of your afternoon. Thank you, and have a good rest of your day. Thank you all. Bye.